I'll probably talk my way through sharing the screen. And then we will begin with the first presenter, Brent Haddad. I hope I pronounced that correctly, Brent.
Perfect.
Oh, wonderful. Thank you. I've been thank you. I'm glad that that's the case. I may check in with some other people too to make sure that I pronounce your name correctly. Please forgive me for that. But I think I'll take forgiveness for that rather than mispronouncing your name. So then I'm so happy to present Brent and his presentation. As managing a pandemic without making inequality worse, the case of Santa Cruz County, California. Now we will show his screen, and then from there, I'll probably keep the screen showing and move on to the next speaker. Everyone, I'm sure you know, has 5 minutes for your presentation. We'll be timing you, and then we'll have we'll reserve time for questions at the end of it. Please place your questions in the Q&A box. Is that right, Melissa? The Q&A, we'll use the Q&A function, and then Melissa or I will read the questions for the group to for the presenters to respond to. All righty. Yeah, here we go. All right, this is Brent's presentation. I'm waiting for it to show.
Well, while it comes up, George, I'll start, and thank you for having us to the meeting. I'm a professor of environmental studies at UC Santa Cruz, and my co-authors are Teresa Ghilarducci, a professor of economics at the New School in New York, and Dr. David Ghilarducci, an expert in emergency medicine, who is also the deputy health director for Santa Cruz County. And starting in the upper left of our poster, we are using the county as our geographic unit of interest, in part because that is where public health financing and focus occurs in many regions of the United States and here in Santa Cruz County. Within our county, we have some serious geographic disparities. And you can see from our map, which is the visual of the Healthy Places Index, and the Healthy Places Index combines measures of economics, education, housing, healthcare, neighborhood characteristics, and environmental characteristics. Blue is worse, darker green is better. And for our county, which is basically that part of the Monterey Bay you see there, the South County is clearly worse off in this index than the North County, the South County being Pajaro Valley and city of Watsonville, North County, cities of Santa Cruz and Scotts Valley. One way that manifests itself is through via economics and low incomes. We have higher incidences in the South County of diabetes, hypertension, and obesity, all of which increase the mortality of COVID cases. And so, and these economic disparities predated the pandemic, and they also, we think, will set the context for future interventions in future pandemics, is this endemic economic inequality. So in the second yellow heading there, what we tried to do with our work was think about, and this began at the very beginning of the COVID outbreak, think about the COVID problem as a dual maximization problem, both improving the public health interventions to fight COVID, but also to maximize the economic well-being of the people in the county. And and that meant for us focusing on the poorest and most vulnerable communities. And that had us focusing on South County. Um, and, and so that's really what this poster is about, is trying to maximize two things rather than one, and economic well-being and the public health response. And so our story is one of the challenges we faced trying to do that. So getting to the next box, as is well known, the public health interventions with COVID are delayed because of the slowness in detection of COVID and the rapidity with which it can be transmitted between people. And so it's just, we can't catch up to it in time to make contact tracing, especially during the very strongest times of COVID. So the way that, turning to the upper right, the way that public health and political leaders responded was to think about really options 1 and 2. And option 1 was the do nothing, leave the economy open, and deal with it. And option 2 was lockdown. And the way lockdowns were considered and ultimately implemented were really not finally defined at all, but simply we're going to lock down entire regions, entire states. And as we looked at that and we looked at the disparities between North and South County, we saw that there was an undue negative economic influence on South County from locking down. And so that's where we began to think about, could we instead target our interventions and target them based on the economic disparities of the regions we were looking at. And the idea there was that by maintaining economic viability in the most vulnerable areas, that in and of itself would have public health benefits. And as I described those earlier prior factors, diabetes, hypertension, obesity, as well as the economic factors of the need for working, bringing in funding, the risk of unemployment, the lack of safety nets, all of that played into this notion that maintaining an economic life in the poorest areas of the region were part of a successful public health intervention. Well, one of the things we tried to do, and we were unsuccessful, and I'll explain why, was to try to set up an alternative COVID detection system using the sewer shed of the city of Watsonville. We got very close in the sense that we identified ideal places to have interventions where we could sample sewage water basically at pinch points coming out of the poorest neighborhoods. We basically got to the point of knowing which manholes to use for sampling. And we got a lot of people to agree to participate, and we got the testing facility set up. This would have sped up the detection, the local detection of COVID incidents by 4 or 5 days, maybe even a week, which would have really made a difference in terms of targeting the interventions and slowing the spread. What we couldn't do was raise the additional funding that we needed to actually carry out that process. And the pilot project, we needed only about $60,000 to $80,000 for, but that turned out to be insurmountable at a time when there were so many other demands for funding for COVID and so much uncertainty. So the network we had in mind of sewage testing failed. But what we learned in getting to the point where we could have done that was that there was another network in South County that was extremely successful. And that was a network that emerged from the region. And it was a coalition of health agencies such as Salud para la Gente and the city representatives and businesses and business leaders and other groups in the community. And they had weekly meetings and really mobilized a public health information response. I should also add that the county was dedicated to providing resources. And so between the city and county providing resources, one of the nice outcomes of South County was that while at the beginning of the pandemic, there was the highest incidence of mortality and disease, now vaccination rates are equivalent to the richer parts of the county, and the case counts in South County are actually lower than North County. So why don't I stop there?
Thank you, Brent. That is quite a inspiring story in terms of the process that you all went through and the lessons that you learned and then applied them as well. I think we have a couple of minutes for questions. Is that right, Melissa, or are we right on the wire?
Yeah, we could probably do one question and then
Yes.
we'll come back at the end if there's an additional questions. George, before we go into that, do you mind expanding the screen? We just had a request.
Okay.
If that's something that's possible.
I certainly don't mind doing that. And I'm sorry, I noticed that as well. Is there anyone who can tell me how to expand it?
Yeah, if you click that box on the top, next to on the top right corner, it should expand.
Oh, wait a minute. You talking about this one? Or this? Oh, here, this box with the arrow.
Let's see. It's going to be on the top, right next to the top right corner of your screen, or that's how it's showing on mine.
Yes.
There's a minus and a square and then an
Yes.
X. Yeah, just try clicking that one and see if that
Click
works.
the square.
Yes, click the square.
Okay. Now, let's see. I want to get back to here.
A little bit more up. I see your cursor there. Thanks everybody for your patience. We want to
Yes.
make sure that folks have accommodations and accessibility to
Yes.
see, or you can provide. I also put the link of where you can access the poster sessions. I can go ahead and post that again for folks if you want to pull that up on your individual screens.
Let me see here. Oh, this is getting out of hand now. Let me see. Tell you what, I'm going to stop sharing for a minute.
Mm-hmm.
Okay. Now, I wonder if this will maximize. I don't want to make the screen any smaller. So I am open to suggestions. Mm-hmm. Let's try again. Share screen. Wait, here we go. I think I've maximized it on my screen. I don't know, did that help at all?
It's still a little smaller on my side. I don't know if that's the case for other folks.
Let me see.
If he hits Control+, he might be making it bigger for him.
Control+.
Uh-huh.
Okay.
Let's see. This.
Is that a little bit better for folks?
Yeah, that's better.
Yes.
Okay. It looks good on my end too. Okay, awesome.
Okay.
Thanks so much, George.
Thank
Take it
you.
away.
Thanks for bringing that up.
Of course.
Yeah, I think I'm thinking that I wish it were much larger. I'm afraid that I may make it worse if I do anything else.
Yeah, no, this is perfect. This is good.
Okay. All right. So we will proceed. Thank you. Let's see, did we have a question for Brent at this moment? No. All right, well, Brent, thank you for that presentation and sharing with us your experiences in Santa Clara. I will now move to our second presenter, and that's our second presenter is Hannah Bichkoff. And I hope I pronounced that correctly, Hannah.
Yeah, you got it. Thank
Oh,
you.
thank you.
Thanks so much. Perfect. Great.
Okay, let me, I got to do some adjustments here, I know.
No problem.
Oh, shoot. This is not good. I am certainly open to any suggestions. Let's try to Control Plus again. If you can, Hannah, if you can tell me when to move it, I'll do so. If that would be helpful. I think I can kind of follow you and just take it down, take it like that. Would that?
That sounds great.
Okay,
Yeah,
I'll just.
that's fine.
Yeah, I'll do my best to follow your presentation. And if we need, just tell me to move it further down, and I'll do that.
That sounds great.
Thank
Thanks,
you.
Dr. Taylor. I'll just
Yes.
say I've had my fair share of Zoom challenges, so I totally get it. And you're doing a great job. It can be really tricky to figure this stuff out.
Yeah, I've got some stuff on the bottom of the screen that I don't need, but I don't know how to get rid of it. I'm sorry.
I'm not sure either.
Yeah.
But yeah, if you want to just scroll as we kind of review the poster, that's
Okay.
totally fine.
I'll do that.
Okay.
All right. Thank you. We'll proceed.
Perfect. Well, good morning, everyone. Thanks so much for joining us. The title of our study is Recovery and Resilience in the Canal Community, an in-depth analysis of economic impacts and solutions during the COVID-19 pandemic. I'm so happy to also be joined today by a wonderful team of research assistants from UC Berkeley, who will be introducing themselves as we review our poster. Can you all hear me okay? Great. So I'll just start off by briefly introducing myself. My name is Hannah Bickoff. I'm a social worker and former MPH student at UC Berkeley. And beginning in August 2020, I was joined by a robust team of community health workers, an amazing community-based organization you'll be hearing a lot about called Canal Alliance, the research assistants who are with us today and a few that weren't able to make it, and also a team of UC Berkeley faculty who really made fantastic contributions to this project. To get into the abstract a little bit, our study examined the impacts of COVID-19 in the Canal community, which is located in Marin County of the San Francisco Bay Area. The Canal is a predominantly low-income neighborhood that is home to mostly Spanish-speaking immigrant residents. And we're all here today because we know and are deeply concerned and also activated to understand and address the historic inequities and health disparities that were highlighted during the pandemic. Also in other counties like Santa Cruz and across the nation as well that were just presented on today. In our particular study, we conducted an informal needs assessment with Canal Alliance and decided to execute a mixed methods research project exploring the specific impacts of the pandemic on the areas of housing, debt accrual, employment, and COVID-19 testing access. Our objectives were to understand these impacts, identify the solutions that were inherent within the community, and ultimately shape local policy efforts to provide community-informed supports, resources, and services. And with that, I'll hand it over to Michelle Wong to share more about the background of the study.
Thanks, Hannah. My name is Michelle. I'm a senior at UC Berkeley. And a little bit more about the community that we focused on is that we interviewed residents and stakeholders living in or working within the 94901 zip code area, specifically focusing on a community known as the Canal. The Canal is located in Marin County, which is California's wealthiest county. Marin is composed of an 81% Latinx majority and home to several different indigenous groups. Despite the fact that only 16% of Marin County's population is Latinx, by March of 2020, they accounted for 74% of COVID-19 infections and 13% of deaths. Unsurprisingly, most of these cases come from the Canal neighborhood, a region where COVID-19 positive testing rates peaked at 40% in August 2020. As a result of the community's high case rate, the Canal stands vulnerable to ongoing economic instability in the aftermath of this pandemic and possibly other future disasters or crises. This focus utilized an exploratory approach to pandemic research in order to further understand methods of containing the spread of the virus, bolster recovery efforts, and expand these interventions to other parts of the county. And I will pass it on to Cesar, who will talk more about the methods of our study.
Thank you, Michelle. Yes, my name is Cesar Guzman, and I'm a recent graduate from UC Berkeley as well. And for the methods of this project, which is the mixed methods community participatory approach that allow the involvement of community leaders from Canal Alliance, which is a local nonprofit. And they help administer a survey that assessed the impact of COVID-19 on Canal residents. Moreover, community stakeholders and public officials were also interviewed, and field notes from those interviews were saved for further analysis through exploratory open coding. Regarding our population of interest or sample population, the participants were identified and approached in person by Canal Alliance community leaders at Canal Alliance's weekly food pantry and via text messages from Canal Alliance's client database. In total, we had approximately 1,309 entries that were completed. 450 in-person paper surveys and 385 online surveys were completed by community leaders, while 474 surveys were completed via social media outreach. A link was spread or disseminated through Canal Alliance social media platforms, Facebook and Instagram. And in addition to that, also 11 qualitative interviews were conducted with community officials and stakeholders who were selected under the guidance of Canal Alliance personnel and staff members. And for the results, you can see down below a pie chart that shows important percentages how Canal residents were severely impacted by COVID-19. And we have this in the form of massive job loss, as well as financial stress related to eviction, housing instability, and debt accrual. And with that, I'll pass it to Ryan, who will talk more about the summary of the key findings.
Thanks, Cesar. Hi, I'm Ryan Allen. I'm also an undergraduate research assistant from UC Berkeley. And so just to summarize our key findings that we found, while respondents did report many health issues, our key findings really indicate more than anything the economic struggles that were taking place in this community. So we could find that actually 97.8% of respondents in the surveys indicated that they were not doing well financially. And among the top challenges ranked were unemployment and housing when we asked them to list these challenges. And so in general, there was also sort of an inability to cover basic household expenses such as food, rent, utilities, et cetera, and a subsequent accumulation of debt as a result. And then when we asked them to list their suggestions for improvement for recovery, these suggestions, we could also see a tie between the suggestions and the challenges that they were facing. So again, the top response is centered around financial relief programs for the unemployment, housing, et cetera. So we started to see that clear trend develop between the top issues faced and the corresponding suggestions for improvement. So with that, I'll pass it on to Kathy to summarize these key themes and conclusions from the findings.
Thanks, Ryan. Hi, everyone. My name is Kathy, and I'm a senior at UC Berkeley. And as mentioned by one of our participants, which we highlighted or quoted at the bottom of the key themes and supporting evidence table, was that the pandemic exacerbated the pre-existing disparities and imposed socioeconomic challenges onto the Canal community. And through our qualitative interviews with community-based organizations, public officials, and community leaders, we see that there's an opportunity for growth and recovery due to the collective effort of these groups. And this group, our report will highlight key areas of policy focus and main themes that offer plans for short-term and long-term solutions. And based on our quantitative evidence, which Cesar mentioned regarding Qualtrics, was that our key themes were housing as a primary stressor, the importance of familial networks for financial support, the relationship between unemployment and surmounting debt, a need for easily accessible services, and investing in pandemic resistance workforce development. And with that, I'll pass it on to Michelle.
Thanks. And in conclusion, we believe that further research on the socioeconomic impacts of COVID-19 on the Canal really should target subject areas and demographics that this study was unable to reach, including undocumented residents, as well as Indigenous communities of the Canal. These groups are particularly vulnerable and face significant barriers in accessing healthcare, resources, social services, and as well securing reliable employment. And with that, I'd just like to thank everyone for their time, and we hope you all enjoyed our presentation.
Thank you so much for that presentation. Again, key issues demonstrated for us in the pandemic across multiple dimensions of identity and social position. We're open for about maybe 1 or 2 questions. We're doing okay time-wise. So I again apologize for that great big black bar across the bottom of our screen. I don't know how to get rid of it. I've never seen it before, but I'm not going to spend time with that. I'd rather us have our questions. And we'll pause while everyone is thinking. And if we feel like when Melissa tells me to pause is time to stop pausing, then we're going to go to our next presentation.
I have a question.
Thank you.
One of the disparities picked up by the Harvard study published last week was that lower and middle income households were hit harder by not having medical care because of the impact of crowded hospitals and busy healthcare providers. If you had to do this research over again, knowing what we know now, would you have added that as another indicator of disparity, or any other indicator would you now add? Because we're going to have more pandemics and we're going to have pre-existing inequalities. What should we do now and what should we monitor now? And I'm glad no one asked us that question.
No, thank you so much for the question. And it was something we definitely considered as we were kind of developing our sort of guiding questions for this study. And what happened was we were really in the beginning months of the surge within that region. And so what the community leaders were really bringing forth was a need to understand the socioeconomic impacts around housing and employment, which is why we focused on that area, because there was a lot of fear around debt and sort of what the outcomes would be for families who were accumulating debt, unable to pay for their housing and whatnot. But we did discuss a lot about how health and mental health as well was really playing a role in the economic disparities. And so one element of the study that we weren't able to sort of dig into too much in our presentation today was access to COVID-19 testing, because we saw that as a major barrier for residents of the Canal. There was a lot of distrust. There was a lot of sort of mythology going around about what the testing meant for the community. And so the community health workers were obviously a key resource in increasing testing and later on in improving vaccination rates. But to your question, I think really looking at pre-existing conditions around health or access to health, that community is actually pretty well situated and close to a federally qualified health center. And there's been quite a lot of work in that area to look at sort of who's attending the health center, what are some of the access issues there. And I think that's something that I know Canal Alliance would be interested in further exploring, and something us as public health students really wanted to dig into, but weren't necessarily able to get to. But
May I suggest that when we do the rest of the poster session, we talk about what we should do for the next pandemic. I think our bottom line is that we should have sewage testing in place, because that would have gotten over the problem of the cost of testing and the stigma of testing, or individualizing it. And we could like swoop in with resources in an at-risk neighborhood. So that's what I've been thinking about, is how do we prepare for the next one?
All right. Thank you for that dialogue. We're, in the interest of time, we're going to move to the next presenter, Francine Rios-Fetchko. I'm going to let's see if this arrow will take me to the next presentation. No. Okay. Shoot.
George, did you want me to pull it up?
Yeah, will you pull it up, please?
Yeah, I can do that.
That may, your screen may be behaving better too.
Yeah. Okay. Let me do this. Okay.
Thank you so much, Melissa and Dr. Taylor, for helping me get that up. So I'm Francine Rios-Fetchko. I'm a research analyst at the Latinx Center of Excellence here at UCSF. And I work together with a group of doctors, including Dr. Ralph Gonzalez, Dr. Alicia Fernandez, Robert Harrison, Brian Taylor, and Robert Kosnick, to look at the variation in COVID-19 incidence rates among different healthcare personnel at a large academic medical center, which in this case was UCSF. So what we did was work together with HR as well as the Office of Occupational Health Services to gather demographic data about all employees who are over the age of 18 who were working between the time period of March 2020 to January 2021, which was our study period for this investigation. And we also gathered information on their COVID positivity rates. So during this time period, it was required that any COVID positivity be reported to the Office of Occupational Health Services. And when a positive case was reported to OHS, they did an internal investigation into whether the case was occupationally acquired or community acquired COVID-19. So for the purpose of this investigation, we focused only on occupationally acquired cases, because we're particularly interested in looking at who within our employee population was most at risk, and what risk mitigation measures needed to be extended. So looking at, or generally for the methods, we did cross-sectional associations between demographics and COVID-19 positivity, which can be seen in Table 1, as well as regressions showing adjusted and unadjusted incident rate ratios for COVID-19 positivity, which are shown in Table 2. So just generally for the purpose of time, I want to focus on the results shown in Table 2. which show adjusted and unadjusted, specifically occupationally acquired COVID-19 incident rate ratios. So here we see that by age and gender, there were no significant differences between different age categories or genders in terms of who was getting COVID. However, when we look at the category of race ethnicity, we do see one group that stands out, which is Hispanic Latinos. And we see in the second column from the right that they have a 1.6 incident rate ratio as compared to whites, who were used as the reference group for this analysis. And this was the only race and ethnicity that was significant for having a higher risk. And this also confirms a lot of the things that we've seen in the community. So a lot of reports have shown increased risk for Latinos and Hispanics across the country, as well as specifically in San Francisco, which we can also see within this specific employee population. Now looking down at job classification, we took job classifications from HR, which break down individuals' jobs into administration, allied health, education, physicians, research, residents, nurses, and support services. And using administration as the reference group, we see that there are 4 job categories that had increased risk of COVID-19 infection, specifically acquired in the occupational setting. So starting with the highest risk, that was support services with an incident rate ratio of 5.36, again here in the second column from the right on table 2. And that's followed by nurses with an IRR of 4.41 as compared to administration, followed by allied health with an IRR of 3.63, and then lastly by residents and fellows with an IRR of 2.07. So what we really were interested in looking at here was among our employee population, which is a population of individuals who are all insured through their employer and all have a pretty easy connection to a medical center through their employment, who really was most vulnerable and most at risk of contracting COVID in the workplace. And so one of the interesting things that we want to point out is that physicians were not among the groups with a increased incident rate ratio or risk of contracting COVID, which is interesting because this is one of the groups that presumably had some of the highest interaction with patients. And this is pointing to the fact that there may be other mechanisms through which individuals are getting COVID within the workplace, whether that be employee to employee transmission or general transmission in the workplace through, lunch breaks, things like that. So some of the limitations of our study is that we were not able to include specific data showing, what level of patient interaction individuals had. The only indication of that we had was job classification. But despite this, we concluded that there is a need to extend additional risk reduction measures to employees who are at high risk, and to emphasize employees who aren't necessarily at risk of patient source COVID-19, but are at higher risk of employee to employee COVID-19 infection. And then lastly, our data does generally support the need for a vaccine mandate for all healthcare personnel working at large academic medical centers, which is already the case here at UCSF, but is not necessarily the case at other medical centers across the country. And this need is emphasized by the fact that there are continuing disparities, not only in the community, but within this population as well, that would benefit from a vaccine mandate.
Thank you, Francine, and your group for that wonderful study that you did and the information that we had. But in the sake of time, and to be fair to our last presenter, Isabel Rutledge, I'd like to now change to her. My apologies for that and the delays that we had, and yet I'd like for her to also have enough, her and her team to have enough time to present. Thank you so much. Unmute. Please.
Yeah.
There we go.
Thanks. Hi, I'm a postdoc at UCSF, and this work involved quite a lot of collaborators, but the two people who probably made the Greatest contribution are also here. So Saki Takahashi and Isabel Rodriguez Barranca. There is a preprint describing this work. So I have a QR code on the poster. So if you want more information, you can look at that. So in the age of COVID-19 variants emerging, making decisions around allocating booster shots as well, it's key to understand the interactions between both disparities in vaccination uptake and access and disparities in the risk of exposure to infection, as different but overlapping communities have been affected by these two disparities. However, obtaining accurate measures of vaccine coverage and also of past infection can be very challenging due to biases in testing, reporting, and also challenges in estimating accurate denominators for particular population groups. So given this, serology, so the measurement of antibodies in people's blood, has been particularly useful for understanding SARS-CoV-2 infection levels in the population. And when there's variability in testing rates and healthcare seeking behavior, which we have seen during the pandemic, serology is an even more useful tool. So in this study, to measure disparities in both infection rates and vaccination across San Francisco, we leveraged a SARS-CoV-2 serosurveillance platform, which we launched in March 2020. And the reference for that is also on the poster. And that platform utilizes residual blood samples, which were taken from 2 hospital networks in San Francisco. So the UCSF hospital network and also the Department for Public Health Network. So that network typically treats a lot of the underinsured and uninsured populations within San Francisco, including San Francisco's homeless community. So we collected around 1,000 samples from individuals who underwent routine blood draws between February 4th and February 17th, 2021. So this was capturing transmission during the first 11 months of the pandemic and also the early rollout of vaccination. And then these samples were tested using 2 different antibody tests or serologic assays. So one test detected antibodies to SARS-CoV-2 elicited by infection, so past infection, and not by the vaccines that are currently used in the US. And the other test detected antibodies elicited by either past infection or vaccination. And then we used Bayesian statistical models to estimate the proportion of the population that had antibodies as a result of natural infection and the proportion of the population that had antibodies as a result of vaccination. And we stratified this by age, race, ethnicity, and zip code of residence. So in terms of the results, first of all, just a caveat, of course, this is from February 2021. So the picture might be a little bit different now, and this is more to illustrate how this type of surveillance system could be used potentially in the future as well. So unsurprisingly, given what we've heard today, and also this has just been well documented, we found pretty stark differences in prior infection rates by race and ethnicity. So we estimated that the risk of prior infection of Latinx or Hispanic residents was 5.4 times greater than the risk of non-Hispanic white residents. We also identified disparities in vaccination coverage amongst the over 65s, which were the age group that were eligible for vaccination during this time period. So we estimated that despite being approximately half as likely to have been previously infected, white San Francisco residents over the age of 65 were twice as likely to have been vaccinated as Black San Francisco residents during this time. Also looking at the map that you can see in the poster, we found pretty striking differences in prior infection and vaccination rates across the city. So across all age and demographic groups, as you can see, zip codes in the southeastern region of the city, which is typically more medically underserved and socioeconomically disadvantaged, had demonstrably higher rates of prior infection and lower rates of vaccination. So it's almost like you can draw a line across the city. You can kind of really see these differences here.
Isabel, may I'm very sorry. May I say, we're at time, but please continue. I'm happy to stay on for a couple more minutes as well.
Okay, I'm
Yes.
just really at the conclusion, so I can
Yes.
just, I
Great.
just wanted to, yeah, just I guess to point out with both of these results, looking at just antibodies caused by, like elicited by vaccination or infection, you get pretty equal levels of immunity across the city and in different demographic groups. So just to illustrate that even if the level of immunity is the same, the pathway to get there for different communities has been very different. And this is something that really has to be taken into consideration in serosurveillance surveys and in monitoring this. And of course, the inequities that have been really highlighted during COVID-19 are not new, but really these considerations of equity really remain an important consideration when we're allocating resources in terms of booster shots and that sort of thing. So yeah, thank you.
Well, thank you. And that was very, very clear. And I recognize that time was a constraint here. Thank you very much for being able to get through your presentation. We see questions in the chat, Melissa, can we answer one of those at least?
Yeah, I think if folks are open, maybe we could ask 1 or 2 questions after this is just the third plenary session, just to allow time for any of the presenters and guests to interact.
Yeah,
or participants
thank
rather.
you.
Oh, hi. I have a question, and I wanted to thank Francine for answering one in the chat. Regarding this last presentation, we've seen a clear pattern that antibodies do wane over time after both natural infection and vaccination. And it's interesting to see how you correlated that against cases themselves. But did you have a way to account for that sort of natural wane in antibodies that we see, and the fact that that could give you a false reading if you happen to test somebody too far down the line?
That's a great question. So there's actually another study that's being carried out. I'm less involved in, but actually Saki is involved with, called the LINK study. And so that is a longitudinal study that has been following people with confirmed COVID infections since March 2020. And so there's like quite good data emerging from that as to how immunity is waning in different like over time. We haven't specifically looked at that here, although this is part of a larger longitudinal survey. So we also have data collected from earlier on in the pandemic, which before vaccination during the first 3 months of the pandemic, which also showed very similar geographic and demographic patterns in terms of who who had the highest kind of like burden of infection.
And sorry, this is Isabel Rodriguez. I just clarification around this answer is that the assays that were used. So yeah, so part of these longitudinal cohort studies, we've quantified antibody waning against multiple platforms, serological platforms, and the 2 platforms that were used for this particular study have shown very, very, very little waning. They are assays that actually are extremely stable throughout time. So we are not particularly concerned about waning for these estimates because of the part of the assays that were used. That's more concerning for other platforms, but less so, for some of, in particular for the Vitros assay is super stable, but also the Roche assay.
That's great to know. Thank you, both of you, and great presentation.
All right. Are there any other questions? Hearing none, I would say our session is adjourned. Thanks again. Thank you very much to all of our presenters, and thank you for the engagement of our audience as well. I think it was a successful time, and we made it through the challenge of time. Thank you, and we'll end this session now.
Great, thank you. Thanks, George.
Yes.